Okay, for the sake of time, we are recording this session as we do with all of our webinars. This is actually our 10th webinar that we've provided and or providing, and very excited and glad that everybody could join us. It sounds like there's some people coming in from tuning in from Alberta as well, which is amazing, starting to expand it outside of the province. My name is James Heckner. I am the community liaison here at Praxis Spinal Cord Institute. And today we are providing a webinar on prevention and treatment of shoulder injuries for people with spinal cord injury. I've actually had some experience myself. I've had two shoulder surgeries, one in 2005 and one in 2008. So I am well aware of the processes of surgeries and the limitations and such of having an immobilized shoulder and arm for the time period of recovery. I also did a quick calculation this morning on transfers, and I'm nearly 29 years in, and very conservatively, I have done about 160,000 transfers in almost 29 years. So yeah, definitely using these shoulders quite a bit, but very excited to have Nafisa Brown, physiotherapist from GF Strong and also our National Clinical Liaison at Praxis Spinal Cord Institute, and Marnie Abbott, who's a multiple Paralympian and of course a person with lived experience, Executive Director, BC Wheelchair Basketball, join us to help present on this topic. I'll pass it over to my colleague, Shannon.
Thanks, James. Hello, everyone. I'm Shannon Rockall. For those of you that haven't met me before, I am an occupational therapist. I've been working in spinal cord injury rehab for the past 25 years, and I've worked at GF Strong, and as well I work with Access Community Therapists now as a clinician. In addition to that, I work alongside James and Emily and Nafisa at Praxis Spinal Cord Institute. I am the regional clinical liaison and provide a lot of education sessions through workshops and webinars such as this. Before we get started, I'd like to acknowledge that Praxis Spinal Cord Institute and the land in which we are hosting this webinar is the unceded traditional territory of the Syilx Okanagan Nation, the Coast Salish peoples, specifically the shared territories of the Squamish and Tsleil-Waututh nations. We acknowledge that participants are joining us from many communities across the province, and we invite you to share the territory you're joining from in the chat. I'd also like to share a story, brief teaching from the Syilx Okanagan Nation. In the story of the four food chiefs, the creator recognizes that humans will be the most valuable beings and calls on the natural world to help them survive. Four chiefs, the bear, Saskatoon, berry, bitterroot, and salmon. They offer themselves as food for the people. Salmon makes a special promise to return each year swimming upstream against the current so the people will continue to be sustained as long as they live with reciprocity and respect. In clinical practice, we often meet people when they are at their most vulnerable, navigating illness, injury, and systems that can feel like strong currents. This teaching reminds us that care is relational. It asks us to consider not only what we provide as clinicians, but how we show up with consistency, humility, and a commitment to learning for those we serve. And I'm going to pass it over now to my lovely colleague, Emily.
Hi, everyone. For the sake of time, before I introduce myself, I'm going to give you this moment to pull out your phones for the QR code that is up. And I'll start again. So my name is Emily Giroux. I am a research associate with the Praxis Spinal Cord Institute, work really closely with James and Shannon on these webinars. And one of the tasks that I have on my plate is really helping our team ensure that we're designing education opportunities that are most beneficial to your clinical education. So these surveys and taking the time to complete them is something we greatly appreciate, and they really just help us understand how effective our learning opportunities are. And they also give us some insights into how we can tailor our content as well as the delivery of what we are providing to best support your learning. And also from an organizational standpoint, it's really valuable in our end to help support us in delivering future learning opportunities to each of you, whether they be virtual such as this or in person. I will also take a moment to share the link in the chat, but thank you so much again. And with that, I will pass it over to Nafisa to get started.
Thanks, Emily. So hi, everybody. As mentioned, my name is Nafisa. I'm a physiotherapist by clinical background, and I've been working in spinal cord injury for about 10 years now. I've kind of worked across the spectrum of care from the pre-surgical orthopedic spine assessment, inpatient acute spine, inpatient spine rehab, and now I'm currently at GF Strong Rehab Center working on the outpatient spinal cord injury program. So I work there part-time, and then I work part-time at Praxis as a clinical liaison. So I'm really excited to talk about shoulders today. They are so relevant for this patient population, no matter the level of injury. And so I hope that with some of our kind of clinical pearls and insights today, you can take something back and use when you're working with clients with spinal cord injury. So this is just a little kind of brief overview of the outline of the presentation. So we'll start by going over anatomy. We'll talk about risk factors for shoulder injury specific to the spinal cord injury population. We'll do kind of a brief overview of a shoulder assessment, and then dive into things that you should look at when you're thinking about treatment and injury prevention, as well as outcomes following shoulder surgery. And then we'll have some spinal cord injury shoulder resources to share with you. So shoulder anatomy, so we'll go to the next slide, thank you. So the first thing I kind of want you to think about is the shoulder itself is not meant to be a weight-bearing joint. Previous to an individual spinal cord injury, we're not using the shoulder to carry our weight from one surface to the next. We're not reliant upon it for a lot of loading or weight bearing. And that's reflected in the anatomy of the shoulder. So it's a ball and socket joint. It's made to move around a lot, but that also lends itself to being less stable. I kind of like to compare it to the hip joint. They're both ball and socket joints, but the amount of musculature and stability at the hip joint is so much more than the shoulder joint. And that's because the hip joint is a load-bearing joint. The shoulder, there's a fine balance of ligaments and small muscles to provide its stability. And after you have a spinal cord injury, if you think about things like postural changes and what you're actively doing with the shoulder, it's a lot different than prior to your injury. So there's lots of shoulders, and what we're kind of hoping to demonstrate with this graphic here is that you have sort of an inner layer of your rotator cuff stabilizer muscles that surround the ball and socket joint, and then you have an external layer of deltoids, pecs, lats, traps, all of those that are kind of more for the gross motor movement of the joint. So there's lots of muscles involved. Go to the next slide, please. And specifically when we talk about the rotator cuff, they're really tiny muscles because they're not really meant to do a lot of lifting, heavy lifting with the shoulder. If there's not enough space because they integrate so much within the joint itself, it's very easy to get pinched off or damaged. And then when you compound that with weak muscles caused by your spinal cord injury, that can lead to poor shoulder blade position, which makes even less space for those muscles, which then can lead to more pain. And again, if you're now dependent on these muscles to do a lot of activities that they weren't really built for, they can wear down a lot easier over time. So here's a little chart talking about your innervation of your shoulder muscles, and you can kind of link this to the level of spinal cord injury. So the more proximal your spinal cord injury, the less shoulder stabilization and activation musculature you'll have access to or active access to. So once you get into kind of the C5, C6 level injury, you're going to have a little more shoulder function. And then, of course, more as you go to the lower cervical injuries. And then presumably you would have full shoulder function in the lower level injuries, so your thoracic and lumbar. That doesn't mean you're any less likely to develop shoulder pain, again, because you're still using those muscles in a completely different way. But when you do have someone with a spinal cord injury come in and you're assessing them and you're doing your treatment planning, it's really important to think about what their level of injury is and how that spinal segment innervation can affect the outcomes that you're hoping to achieve, as well as what your findings are on your assessment. So we'll pass it over to Marnie for a little introduction and just talking about some lived experience.
Oh, you're just on mute, Marnie. Sorry.
I thought I unmuted, but I was in slow motion. Sorry about that. Hi, everybody. My name is Marnie Abbott. I've spent the last 40 plus years living with a complete T3 spinal cord injury as a result of a skiing accident. Definitely the accident changed my life a lot, and learning to live with a disability was an extremely challenging and difficult situation, but I was really lucky. It was in 1983 when I got hurt. I met a gentleman named Rick Hansen, who I'm sure many of you have heard of, and he told me about a lot of things that were still available to me, and I ended up having a long, rewarding athletic career involved in wheelchair basketball and traveled to Paralympics and all kinds of great things. So my shoulders definitely took a lot of training. I wouldn't say abuse, actually, because it was actually when I ended my athletic career that I started having all the troubles with my shoulders and really noticed a lot of changes in my body and really felt more of the impacts of not training and how it impacted my overall strength and sort of my daily living. And then I really started to develop some osteoarthritis, and having that constant daily debilitating pain was extremely hard. Sleeping became very difficult. The fatigue then led to mental health issues. And so overall, it was extremely, it wasn't just daily shoulder pain. It was like an overall impact on my life. So having the full shoulder joint replacement surgery, which we'll talk a bit about later, was basically changed my life. So yeah, thanks.
So we'll talk about a few risk factors for shoulder injury, again, trying to keep it specific to this population. Next slide, please. Thank you. So I've split these up into kind of what we like to refer to as non-modifiable and modifiable risk factors. So of course, there are certain things that you just can't control for, but as a clinician and even as an individual living with a spinal cord injury, still important things to be aware of when thinking about shoulders. So the first, as I kind of alluded to earlier, is the location, neurology, and duration of your spinal cord injury. We see that generally higher level injuries and complete injuries are more prone to shoulder injury, as well as those who have a chronic spinal cord injury as opposed to an acute spinal cord injury. And that just really talks about how much the shoulder has been used over the course of their time being injured versus freshly acute. You're kind of working with shoulders that may not be as heavily used. Age, of course, so regardless of whether or not you have a spinal cord injury, you're going to experience some degeneration as we age, so that definitely plays a factor. It has noted to be higher in the female sex. We might have some resources on why that is, I'm not too sure, but that's what's been found in the literature. Of course, a history of previous shoulder injury, you're working with something that's already damaged, that's already been injured, that's going to affect your ability to use and maintain your shoulders long term. Anything that has poor connective tissue capacity. So we talked earlier about how the shoulder is dependent on ligaments for that stability underneath the rotator cuff. And so anything that's going to cause those ligaments to not be as robust can certainly put you at risk of developing shoulder injuries and shoulder pain. Dependence on upper body for everyday tasks. I call this non-modifiable. It maybe can be somewhat modifiable, but depending on how much you need to use your upper body to do the things that you're doing day in and day out will affect your likelihood of developing pain. And then SCI-related muscle imbalance can definitely cause postural compromise, and that does progress over time being injured. And that's going to certainly affect things. Also, it's sort of just the lack of use or immobilization of the shoulder girdle muscles limits your active joint movement. And then over time, that's going to lead to shortening of the muscles and tightness of the shoulder capsule. So all of these things are sort of non-modifiable risk factors that individuals and therapists, clinicians should be aware of. And then the next slide I have modifiable. I say semi because we know that not all of these are a quick or easy fix, but things that you can work on changing in order to protect and preserve your shoulder health. So things like flexibility, range of motion, strength in the innervated or partially innervated groups, if you're able to build that, is very helpful. Things like posture, paying attention to the demand that you're placing on the shoulders, spasticity management, so looking at medication, neurotoxin, electrical stimulation, any of the modalities and treatments to try and reduce spasticity. Body weight, especially if you are propelling yourself in a manual chair or ambulating with a gait aid, you're having to support your body weight with your upper extremities and your shoulder. And that definitely plays a part in likelihood of injury. General balance and environmental setup. So these are all things that you can look at modifying or potential targets for clinical treatment. So very briefly, we'll go over what a shoulder assessment should involve. And of course, it's very dependent on the individual, but these are things to keep in mind. So your subjective history is going to be your number one kind of where you're going to get most of your information from. And then in your objective, you're going to see, okay, does this fit the picture? But basically, when you're talking about history, you want to note the type of injury. What does daily life look like? How much demand on the shoulder is happening? Previous treatments that may have been tried for the shoulder, and if there's been a previous injury or disorder to the shoulder. You also want to think about, okay, what are our aggravating and relieving factors if your client is experiencing shoulder pain? And then when assessing for the pain itself, it's really important to look at location, but also characteristics of the pain. Pain is not unidimensional by any means. There's different types of pain. There's neuropathic pain, there's musculoskeletal pain. So it's also very important to get a good pain history because it might help you rule out other issues that could be pretending or masquerading as shoulder issues. During your objective assessment, don't have your client do this. This is very ambitious, but you're going to start with your basic inspection. You're going to look at what is their scapular position and posture. Is there an asymmetry, both left and right, front and back? Are there force couples out of balance? And so is something at the front much more active than something at the back? And is that pulling the shoulder in a certain direction? Palpation can really help you figure out if there's any abnormal posturing at the shoulder, any risk of subluxation, a good ROM and strength assessment. There's shoulder special tests that you can apply to this population. You can do your rotator cuff testing. A functional review is going to be very, very important. If your client is transferring themselves in and out of their chair or getting on and out of bed, you want to really make sure you're looking at how are they using their upper extremities to do that. Seating plays a really big part as well. What is their posture in sitting? What does their seating system look like? And is it really optimized for that shoulder position? And that goes into kind of your type and setup of your wheelchair, or if you have someone who's ambulatory, looking at their gait aid, if they use one, is the height okay? How much pressure are they putting through their shoulders? Sleep position is one that kind of I tend to forget about because you're seeing the person when they're awake during the daytime, but really getting into sleep positioning can be quite helpful, give you helpful clues to figure out what's going on with the shoulders. And then just other functional items here. And this is a list of some outcome measures that are specific to shoulders or components. So I know within the wheelchair skills test, you can take a look at how are they doing certain wheelchair skills and is that impacting their shoulder. So lots of cool and good little things to pay attention to when you're doing your assessment. These are some of the most common shoulder pathologies we see in spinal cord injury. So anything to do with the acromioclavicular joint, certainly with all the forces you're putting through it. For example, during transfers, impingement. If you think about, again, if you have someone who's wheeling a chair, they're constantly pushing their arms forward and coming into that rounded forward position. And that really lends itself to a risk for impingement. Rotator cuff tear, which we've discussed, long head of the biceps, arthritis, dyskinesia of the scapula. These are kind of the most common things to be aware of when you're doing your shoulder assessment. And then treatment. So you've assessed the shoulder, you've kind of tried to identify some of what is going on, what's the potential issues, what are our target risk factors we want to look at, as well as what are our treatment goals and what are we going to do. So step one is to set it right, stretch it out, and strengthen it up. So this is kind of a 4-step guideline of number one, looking at posture. So is there anything we can do at the neck, in the torso, at the shoulder blades to really optimize the posture to reduce the amount of forces that are actually being put on the shoulder? I think there was an image earlier on in the presentation, but basically the further forward your head is of your shoulders, the more weight in pounds is actually being put through your spine and through your shoulders. So it's very important to look at working on posture within what's possible for the patient. You might have someone who's 40 years out from their injury and their posture is probably pretty set, but is there anything that you can do even to make a little bit of a difference? I think would be very worthwhile exploring. Stretching, as we spoke about earlier, the joint capsule, everything gets tight when you're not using it or not using it as optimally as prior to the injury. So we want to look at maintaining the length of the muscles to help maintain that balance. Again, when we're wheeling a manual chair forward, we're getting really strong in the front of our shoulders, and we're also getting really tight in the front of our shoulders. And that equates to getting really weak and really long at the back of our shoulders. And that's going to throw everything out of proportion. So can we focus on stretching and the muscles that are tight, strengthening the muscles that are loose, basically? And that goes into strengthening. So you do want to do what's safe for the joint itself. So you want to work within an available and safe range when you're doing strengthening, and gradually increasing the load as possible. And then the last one, and perhaps the most important one, I would argue, is taking rest. It's really important to take breaks, even if it's just going back to bed for a few minutes, which I know does involve a transfer there in and out, but even if it's in your chair, just taking rests as needed throughout the day to give your shoulders a bit of a break, to help prevent kind of long-term damage. So we spoke about posture, but that extends in multiple positions. So sitting, bed, again, if you're ambulatory, looking at the individual in standing and in walking, what does their posture look like there? When you talk about equipment, you want to optimize the type of gait aid or mobility aid that you're using to reduce the demand. Something that's quite common is a lot of walkers and walking poles that I see are often set too high because you want to stand up straight. But what that can actually do is cause then the shoulders to elevate and put a lot more strain. So you want to encourage upright posture, but also minimize the amount of strain that you're putting on the shoulders. So really working on an optimal height of your gait aid is going to be really important. When you have someone who's using a manual wheelchair, really looking at the setup, what are the angles of the chair? What are the seating components? Can we try and get something as lightweight as possible within the realm of what's available funding wise? And then, again, talking about angles, really looking at things like seat slope, wheel access, tippiness of the chair, all these things to try and make it as easy as possible for the individual to move around. And if you have someone in a manual wheelchair, you can consider a power assist or a power add-on. So that's where you have a motorized wheel that attaches to the manual chair and can be activated, for example, when going uphill or on difficult terrain or longer distances, to allow the individual's chair to still move, but not have them have to continue pushing as hard. And some people may need to make the transition to a power wheelchair, or if it's somebody's first wheelchair and they're on the borderline of being able to use a manual versus a power, really having that discussion on goals, what's important for the individual, and also what's going to benefit them most long-term in terms of wheelchair setup. Reducing lifting and pulling of the chair. So many individuals are getting into their cars and lifting the chair up and over. It's a really awkward position. So is there anything we can do to optimize that? Wheeling against resistance. So looking at the surfaces you're wheeling on. Things like carpet, grass are always going to be more resistive than a hardwood floor. So are there things that you can modify to their environment to make wheeling a little bit easier? And then if this is someone who's working or just even around the house, really wanting to get a good ergonomic setup as best as you can. So here's an example of a couple of pieces of equipment that we use regularly with this population, and Shannon can probably jump in as well. The item on the left is called a front power assist. So it's got a motorized wheel with a battery and a throttle style control, and it clamps onto the front of the manual wheelchair. Lifts up the front casters, effectively turning it into 3 wheels, and then allows the individual to drive the chair. So a lot of individuals will use this for longer distances, commuting, going off road, just ways to reduce the demand on their shoulder. And then the item on the right, sorry, Shannon. And then the item on the right is called an independent lifter. So this is something that the individual can set up on themselves and use in conjunction with an overhead lift system to transfer in and out independently.
Yeah, absolutely. And these are 2 pieces of equipment that, I'm prescribing them more and more often as people are aging with spinal cord injuries and as the technology increases as well. So just, talking a little bit about the independent lifter. This is the only product that I know of that is like an overhead lift that you don't require a sling for. And it's fantastic. Also, this device, I've used that for people to get onto horses and into tractors, some different setups as well that would not be possible without this type of lift, but also for preservation of upper extremity joints. It's a great device. The power assist devices, that's probably I'm going to say that is probably the single device that has made the biggest difference in my 25 years of working in spinal cord injury, and the newest change. And it's something that I am prescribing for my clients right away. So we're not waiting until their shoulders are bad. We're doing this so that their shoulders don't get bad. So it's about preservation. Let's maintain those joints healthy over the long term. So these are fantastic because you don't have to replace your vehicle, right? In comparison to like a power chair, you can maintain some of your strength and range and function by using your manual wheelchair. But when you're going out longer distances, outdoors, tricky terrain, then you can use those. This type, the front drive, is, and there's a number of different models and brands, but those are the best, I would say. Like, we use those a lot for the Okanagan, and just for people sort of in more regional areas with snow, grass, that kind of thing. You can get around much better with them, where some of the other units where your front casters are still hitting the touching the ground, then you can be limited, still have extra demands and having to do wheelies and that kind of thing on your shoulders. Another thing, and you mentioned it, Nafisa, but is the weight, when you're prescribing equipment, making sure that it's lightweight, right? All the components. And that is all justifiable. Again, you can look at the CAN-SCIP guidelines, best practice guidelines, and it will talk about what we should be prescribing as clinicians for the preservation of the joints. And we will send out in that link in the email, like we always do with all the resources afterwards. But that is something that I use constantly, referring to the best practice, and this is what is recommended. So we're doing our clients a disservice by not recommending them equipment that is going to preserve these joints for a lifetime of doing transfers and mobility and function.
Yeah, that's a fantastic point. I think there was a question in the chat on what the name is of the lift device. And correct me if I'm wrong, it's an independent lifter. Shannon, on the right here?
Yes.
Yeah.
Yep. That's
So
right.
it's called an independent lifter.
Yeah. Yeah.
Yeah. Okay. You're welcome. So when we get into preventing shoulder injury, like Shannon was saying, a lot of it is really getting ahead of the game. If you have someone who's now using their shoulder in a way that it was not meant to be used, that to you as a clinician should start ringing some bells and saying, okay, well, this person has had a life-changing injury. They're now going to be dependent on these joints to maintain their independence for decades to come. How are we going to preserve, maintain the shoulder function that they do have and set them up for success down the road? So I think it's really important to look at, and you don't want to tell someone don't do anything, because they'll turn around and they'll go do it anyways, right? Like, it's all about quality of life. So certainly I would never tell someone don't go to wheelchair sports. Don't wheel your manual wheelchair around outside. You must stay inside on hardwood floor only. Like, I'm never going to tell anyone that. But where it does become important is to just think about what extracurricular and what activities they are doing that require repetitive use of the arms, and think about it in moderation. And if you have someone like Marnie, who's an elite wheelchair athlete, what program can you prescribe them, or what can you give them to work on to allow them to optimize their shoulders to continue participating in the activities that they want to do in the healthiest possible way? So modification, taking rest as needed, looking at the amount of transfers you're doing, what that difficulty level is, and what the setup is. So looking at, in this photo, you can see this individual has their head kind of facing away from the direction that they're transferring to. And that's something called a head-hip ratio. And that's going to make it a lot easier for them to lift their body weight, as opposed to if they were just sitting upright and trying to shift their bottom over. So looking at different transfer techniques, going to level surfaces or even a little downhill can be helpful for allowing gravity to assist you. Car transfers are always a really tough thing. Oftentimes the wheelchair is a lot lower than the car. So how do we go uphill, and are there any devices or things that we can use to assist to break that transfer up into maybe 2 transfers or make it as beneficial for their shoulders as we can. Look at reducing the amount of time that you're working at or above shoulder height. Anytime you have your arms up like this for an extended period of time is going to put a lot of demand on the shoulders. And so it's all about activity modification where appropriate, and lots more. I'm sure I'm missing a lot, but if you take anything away from this, it's that you want to preserve and maintain the integrity of someone's shoulders who has a spinal cord injury, because they're going to be using them for years and years and years. And so there's lots of different ways to do that. These are some guides. So like Shannon mentioned, there'll be an email sent out with links to each of these resources, but there's sort of your STOMPS program. BCH has a Taking Care of Your Shoulders booklet that's freely available on the Patient Health Education Materials website. That's actually where I got those kind of 4 steps and those photos from for shoulder management. So that's a really good, very basic, but very applicable handout. SCI Action Canada has a couple of really good toolkits, physical activity guidelines, and SCI BC, which for those who don't know is a peer, kind of a peer network in BC that connects people with spinal cord injury across the province. And there's a program called Peer Health Coaching where you can actually be matched up with someone who is a peer, and they will guide you through sort of ownership of your exercise program, accountability, talk you through some options for continuing to work on being physically active in a safe way. And this way you really get to learn from someone with lived experience. And so that's really, really helpful. For those that are local to the Lower Mainland, there is at the Blesson Spinal Cord Center, there's a place called the Park Gym, the Physical Activity Research Center, and it is free for anyone to use who has a diagnosed spinal cord injury or spinal cord impairment. There's a bit of an intake, just a quick intake process, but you can come in and use adapted equipment free of charge. There's lots of really good machines that are wheelchair accessible to work on your upper body, lower body, anything really, but it's a really good resource. So I will maybe also make sure that that gets sent out as well. Okay, surgery. So as James and Marnie will kind of take us through, there's sometimes it gets to a point where you've got to have surgery for your shoulders. It's, you've been using them in this way for so long, and it's gotten to the point where they're no longer serving you. But what's really important to know is when you think about surgical intervention in this population for the shoulder, there are mixed results, because you are now doing a very invasive and traumatic procedure to a joint and a setup that is that you depend on, and now you're not going to be able to depend on it as much during the recovery process. It may not be appropriate for everybody. I know we have older population here, but even younger individuals, it really is a long discussion process between the individual, their clinician, their surgeon, really we know that this is going to be a really challenging time and a challenging procedure. So what are the pros and cons truly for this? After surgery, you have to rest it while it heals. But when you need to use the joint that's just been operated on for your day-to-day living and your independence, that's really hard to wrap your head around and really hard to get through. And oftentimes you're not allowed to bear weight, or you have to have the shoulder in a sling and immobilize it. And so maybe I can turn it over to James and Marnie just to chat a little bit about what that looks or feels like as an individual with a spinal cord injury.
Do you want me to go, James, first?
You give her. Yeah,
Okay.
I'll jump in here after, you bet.
And then maybe, sorry, I didn't realize I skipped a slide, so we can go back to that after you guys are done talking, but I really want to give you guys an opportunity to chat here.
I think you touched on some really, really key points. And I think one of the things about making the decision to have surgery, it's scary. It is scary. And even though James talked me through it, I had a great surgeon who talked me through it. I had a lot of prep. After the surgery, it was like a punch in the gut. Like I was not prepared for the mental fortitude that it was going to take for me to kind of get through those first few weeks. And I think the thing that made it more difficult was that it's difficult as a person with a spinal cord injury in BC to have any kind of surgery and then to go to any kind of a rehab facility where they are capable of taking care of you. It was hard for me. I just had this expectation that I would go to GF Strong, and because that's the place where people with spinal cord injuries go. But they told me quite quickly that no, that wasn't the case, Marnie. You're not going to GF Strong. That's for acute injuries, and you have to figure something else out. And we didn't really have a good plan going in. My surgeon was great. He just kept saying, "Don't worry, we'll figure it out. We'll figure it out." And he did eventually, but it took a lot of work and a lot of advocating. And I finally got into a place called Holy Family, which is an amazing facility in South Vancouver. It was actually for an age group a little bit older than what I was at the time, but I've kind of passed that threshold now, so I guess it's all okay. But once I got in there, the team was fantastic. And it was not just about the shoulder and the surgery. It was about me and everything I needed in terms of what was going to happen next steps, if it was a power chair or what I needed at home and all the things I needed to figure out. So it was just that small gap between the post-surgery and getting into the rehab that was quite a stressful period for me. But luckily I had people that had gone through it before that had really advised me well. And even though I was, I kept preparing myself mentally and trying to, convince myself that this was the right thing to do. Yeah, I didn't believe it that first week. It took a while for me to kind of come around to it. But and then with my care and with the physios, the stuff that we did while I was there healing up, it was pretty minimal because I wasn't allowed to do a lot because it was really right after the surgery. So there was a period of time where I was still in bed for a few days there. But the whole team, everybody came to visit me and talk to me and really helped me through it. Mentally. And I think that was one of the things that led to really the success of it all. But I had a full shoulder joint replacement. So they literally cut off the top of my humerus and replaced the top there. And then I have a Teflon kind of coating on the other side. And I have zero pain in my shoulder. I can't believe the difference. It was like a load was lifted off of me, not having that daily pain. So even though it was a difficult decision to make and it was a little bit tough to get through it, with the right support, I think, and the right things in place, people can manage it. And I think that slide that shows where there's mixed success, I think that's because the healthcare system has this expectation that people with spinal cord injuries can be treated the same as every other patient, and they go home too soon. And then that's when the surgery is not going to be successful, because it's almost, as a person who only has 2 limbs to use, even just moving in bed slightly, it's almost impossible to keep your body completely immobile. So, having to go home and to try to do that, even if you have a fully able partner or someone there to help you, I think it would be really, really difficult. So I think James actually had some of the same experiences as me. So maybe I'll pass it over to you now, James.
Yeah, sure. Thanks, Marnie. Very, very similar experiences. Like I had 2 shoulder surgeries, one in 2005 here in Kelowna, and I was sent home the same day of the surgery. So as you could imagine, like there was nothing really put in place, and the surgery was almost doomed for failure right from the beginning, because you're relying on family and such to be able to support you. I did have a hospital bed that I'd set up in the living room to, to accommodate that. But, as you can imagine, you're supposed to keep your limb totally immobilized for 6 weeks while it heals. And then the following 6 weeks, of course, is very minimal motion. So the second surgery that I had was in 2008. And it was, even though it was successful, which was great, I was well prepared for what needed to change for the second shoulder surgery. So I did end up going down to Vancouver and actually having the surgery done in Vancouver. And then it was actually at the UBC hospital, and they're similar to your experiences, Marnie. Still didn't have a full plan on the recovery process, because the system is set up that this is a shoulder surgery, this is the process, and not necessarily a process put into place for somebody that is paralyzed or have limited lower limb function, for instance. But the biggest thing of all for that I experience, or that I am well aware of, is how do you manage bladder, bowel, skin post-injury, post-surgery? And for me, that was the biggest hindrance, because you're immobilized down to one limb. Trying to transfer on and off of a commode, especially at home, is not going to work well. And then when so basically, similar instance to you, I was transferred with some strong perseverance, to go from the surgical ward to basically it was a geriatric or orthopedic ward. So I was 30 years younger than the next patient on the ward, but I did learn a lot from the veterans that were in my room, that's for sure. But still, it was great to be able to. Staff were excellent. They gave me the supports that I needed for managing bladder, bowels, and providing the right surfaces so that it didn't acquire a secondary complication, pressure injury, on the ward. And they did give me a power chair as well to use, which was excellent, to be able to buzz around the university, go out for dinner, that sort of thing. Psychologically, that is the biggest thing that I found, the biggest challenge, because you are going in to a scenario where that you are going to be immobilized for 6 weeks. There's going to be 6 weeks of steady physiotherapy, and then there's going to be almost a year post that of outpatient physiotherapy to get the shoulder at least into fully working order. So if there's anything that I can say about somebody that is considering a surgical option, just be well mentally prepared that you are going in for a long haul, and just, persevere through it, because those few weeks, it takes a little bit. I remember looking at my manual wheelchair for the few weeks that I was at the UBC hospital, and I just kept saying, I'm like, I'm going to be in you again. So just, that's how you kind of have to consider these things. So yeah, there's a lot more to say about this, but yeah, glad that we were able to share our experiences. Did you want to go back to that slide, Nafisa?
Sure. Actually, I think I should have maybe put it after this, because it ties in well to what you and Marnie kind of just discussed. Is if you have someone who's looking at, okay, this has got to be done, we've got to do this surgery, how are we going to prepare for it? So in addition, kind of at that bottom point, you've really got to think about and prepare for that impact psychologically of what your life is going to look like for the next year and a bit. And so, leading up to surgery, try and keep your activity and mobility as you're able to, maybe do some modifications. Is there some prehabilitation that you can do? Is there some strengthening program, range, activity modification, something you can do to really set your shoulder up for success post-operatively? And then where you're not able to do things for yourself because you're now down a functional limb, looking at advanced planning if possible. So can you rent things like a power chair or a lift, which I know is not cheap, but is there something that you can get access to that will make your life a little bit easier and allow your shoulder to heal post-operatively? And then thinking about skin health, do we need to go onto a pressure relieving surface? What is that microclimate going to look like? Because you're not going to be as mobile. You're not going to be able to turn yourself as easily in bed. And so that's going to put you at a higher risk of developing a pressure injury. So really thinking proactively about those sorts of things. Accommodations, is there somewhere where you can convalesce? Can family, friends, can there be some support to help do some of your ADL, your IADLs and some of your ADLs, or assist you with those to make life just a little bit easier for you while you're healing? And bowel and bladder management, what does your typical routine look like? I had a client once who in return, not necessarily bowel bladder, but hygiene wise, lowered himself into a tub, and that's how he showers and bathes. And that wasn't going to be feasible post-operatively. So we really had to come up with alternate bathing options for him for the next 6+ months while he was recovering, because that was not going to be a movement he was going to be able to do functionally. Looking into funding. So what options are there for funding for some of these accommodations and equipment? What does your client have access to? What foundations can you look for? Different ways to access funding. And then looking at deconditioning. If you're going to be out of commission, so to speak, for a while, you're going to get deconditioned. So are there exercises you can do in bed? Is there a way to get your cardiovascular system pumping while you're not as mobile as before, and doing a safe and gradual return to activity, because you want this to be a successful surgery, and rushing back into doing the things that you were doing before may not be feasible or safe in this sense. Yeah, can go ahead there, James. Sure. Yeah, so I don't know if James, Marnie, or Shannon, if there's anything else you wanted to add.
I had two questions actually for you, Nafisa. One of the things I was suggested was to on the arm ergometer bike, stationary bike,
Yeah.
it was suggested to go backwards on it. Is that what you would still recommend?
Yes and no. I used to recommend that, and I do like the idea of going backwards because it's getting away from that sort of forward rotational movement that you're doing so much when you're wheeling. I've gotten away from it recently because it's still a bit of an awkward motion. I really like to focus on sort of banded, weighted, pulley, more functional exercises to strengthen those posterior muscles as opposed to the ergometer. I think if you're going to use the ergometer for like cardiovascular exercise, it's a really good option. I haven't recommended going backwards on it as much though recently, I would say. It's just not as nice to me. Personally, I like something that'll get your shoulders down and back, whether that's resistance bands, pulleys, functional movements like loading through the mat, things like that.
I would just quickly add that even though it is scary and difficult and sometimes hard to navigate, if you have clients that are in constant pain, encourage them to get it done, because my life is completely different now that I don't have that daily pain. And I waited 5 years too long for it. I should have had it done way sooner, but, and I think I've been chatting, and I was just mentioning to Shannon and James earlier, is that there's a group of aging folks with SCIs that are getting together and chatting about different challenges and things that we're facing as we get older. And a lot of the things we're kind of equating back to being newly injured. But when you're newly injured, you have all those sort of supports in place to help you kind of navigate it. But when you're old, you don't necessarily have that same system. And you kind of have to find that for yourself and advocate for yourself a little bit more. So if you do have clients that are experiencing that pain, even though it is a little bit tricky, I just feel so much better, and my life is so much better, and I'm stronger, and my transfers, everything is feeling good. So yeah, I just add that as a little positive ending, maybe.
I agree. One of the other things you mentioned is sleep positioning. Is there documentation or anything on, though, that we should be considering or looking at for sleep positioning? I mean, I bring that up because that happened last night. I'm trying to find a position where the shoulder isn't going to be, sore, but at the same time, as you're resting, what's the best way to have your shoulder so that it kind of recover from the day before, in a sense?
Yeah, the VCH document has some kind of lots of pillows options, but some suggestions of sleeping positions. I don't know, Shannon, if you know of any other resources.
No, that's a great one. And we'll send it out. We sent it out at the end of last webinar. We'll send it out definitely with this one. But also it's so client dependent, right? And the situation dependent, but using your clinical reasoning and what the issue is, what the challenges are, what environment and surfaces you have to work with. But there are a lot of different shaped pillows out there now that can be helpful or hindering, depending. Yeah, trying out some of that and working through it to see what works for your client.
I usually like to recommend, like, if someone's a side sleeper, whatever their top arm is, having that supported so it's not being pulled. And then if you are we have a lot of clients who sleep prone, and so making sure that maybe do you need a couple of like small shoulder pillows or a small sort of chest pillow just to support you this way. Lots of different options, but yeah, as Shannon mentioned, it's often very much client dependent.
One more question, if there isn't any questions. I'm learning more than anyone else, I think. But the pain types, my physiatrist in Vancouver was mentioning that it sounds like it's more nerve pain in the shoulder than musculoskeletal. However, how would you know the difference?
As a general rule of thumb, and again, this can be very different in different people, when you think about nerve or neuropathic pain, it's so commonly described as a burning, a sharp, a shooting type of pain. You can get a bit of an ache with it, but usually it's that sort of pins and needly, nervy, sharp pain. And then you have your musculoskeletal pain, which is generally more mechanical in nature, so a little bit more achy. A lot of people describe like a feeling heaviness of the arm and the shoulder, can be quite mechanical and muscular as well. That's a general rule of thumb, but there's often overlap depending on your level of injury. If you've got cervical spine compromise, if you remember that chart that we showed, a lot of the muscles that go in and around your shoulder are innervated through the cervical spine. And so it's very, very common to have an element of both affecting the individual. That's not to say someone with a lower level of injury couldn't eventually develop it, because if you're a lower level injury, but you've lived your life with your head forward, with your shoulder forward, you may eventually develop some type of nerve pain coming from your neck regardless. So those are the kind of general differences that I find between the two.
Thanks.
Any other questions from anyone? here's a fantastic list of resources that Nafisa's put together. We will send out all of these to you with the actual links to your email, so you have easy access to it. As always, James and I are available for any questions and follow up. As of right now, for next month, we don't have a webinar scheduled right at this moment, but we will certainly send out an invite as soon as we do. And thanks so much for attending today. And thank you so much, Nafisa and Marnie and James, for sharing your personal and professional experience.